Dear doctors, very good evening. Greetings from Alembic Pharmaceuticals. Myself, Ms. Trupti Patade, Head Marketing of Elena Division. In our constant endeavor to disseminate knowledge, Alembic Elena Division is always at the forefront to partner with healthcare practitioners and conduct interesting and engaging scientific programs across India. One such knowledge sharing initiative is Knowledge Beyond Boundaries, where we try to bring in the expertise of leading doctors from across the globe. It gives me immense pleasure to invite our international speakers, Dr. Moshe and Dr. Budi, on this platform. Also, special thanks to Dr. Nandita for always encouraging and supporting such knowledge sharing initiatives. It is lovely to have with us Dr. Pratik Tambe, who will be moderating our session today. So before we go ahead, I would just like to highlight a few things about Dr. Nandita Palshetkar, although she needs no introduction, but all of us are already aware the positions that Dr. Nandita holds. She is the past president, senior vice president, chairman, Perinatology Committee, FOXY. She has been the past president of FOXY 2019, past president of IAGE 1718. She has been the past president, Association of Maharashtra Societies of Obs and Gynae, that is AMOGS 2020-22. There is so much more to talk about her. She is the medical director of Bloom IVF Group, which are the IVF centers across India. She is the FOXY representative to International Federation of Gynecology and Obstetricians, that is PIGO. So, no words can describe the contribution of Dr. Nandita to this entire gynecology therapy as such. So, thanks a lot, Dr. Nandita, for being with us, supporting us, and always encouraging, such kind of initiatives. Thank you so much, ma'am.
Thank you, Trupti, for that wonderful introduction. And I think welcome everybody. This is the first of the series, Knowledge Beyond Boundaries, where we are going to have a lot of international people speaking on different subjects. And first, I should just say that it's the brainchild of Mr. Atul Suri and Artika. They've really worked very hard on this, and they were very keen that all our audience gets to hear varied uh, subjects. So today I'm really happy that we are taking off on with such fabulous speakers, Dr. Moshe and Dr. Budi. They are my colleagues, international colleagues, and really looking forward. Sorry, due to medical emergency, I've had to record my talk, but I'll definitely be with you all in future. And thank you very much, Subhu, for your support. And Pratik, I really must thank you for coming in on an emergency basis and helping us out. So I'm going to sign out now, and Pratik will handle the session, and
Thank you
I'll
so much,
remain
ma'am.
online. Thank you, Trupti.
Thank you.
Thank you very much.
So, short introduction of Dr. Pratik Tambe. So, who is the ICOG Secretary 2026-27. He is the IVF consultant and gynec endoscopic surgeon, Ashirwad IVF Mumbai. Again, Pratik holds a lot of awards and recognition to his kitty. Now, to name a few, he is the recipient of 36 MOGS, ISAR, Foxy, and MOGS prizes and awards, editor of 32 books, 4 Foxy houses and handbooks, 9 GCPRs, 11 key practice points. He has contributed 100 plus chapters, invited faculty for 1,000 plus events, and organized 800 plus CMEs. He has been a convener, ICOG Reproductive Medicine course 21-25. He has been a peer reviewer, Journal of Obstetrics and Gynecology of India, 2012 onwards. So, sir, welcome you on board, and thanks for accepting our invitation on a short notice and agreeing to be a part of this knowledge sharing platform as well as to moderate today's session. Thank you so much, Dr. Pratik. I would like to now hand over the session to you. Thank you.
Thank you very much, Dr. Nandita Palsetkar ma'am, and the entire backend team of Science Integra for putting together a wonderful program in association with Alembic Pharma. Knowledge Beyond Boundaries promises to be a wonderful initiative. Congratulations on setting it up. And without further ado, I don't wish to keep our international speakers waiting any longer. So we'll proceed with the first talk. Our first speaker of the day is going to be Dr. Budi Viveko, and sir is going to be speaking on optimizing endometrial receptivity, the role of dydrogesterone and sustained release in endometrial priming for ART. To introduce Sir briefly, He is well known to all of us as an international faculty at several conferences worldwide, including in India. He's visited us as well. He's a member of the Health System Strengthening and Respectful Care Committee of PIGO. He's the chairperson of the Reproductive Endocrinology and Infertility Committee of AOFOG. He is also president of the Asian PCOS Society, president of the Indonesian Society of Obstetricians and Gynecologists, and a past president of ASPIRE. Currently, he is the Vice Director of the Indonesian Medical Education and Research Institute Faculty of Medicine Universitas Indonesia. May I present to you Dr. Budi Viveko. Over to you, sir.
Thank you very much, Mr. Chairman. Thank you so much, Nandita, for having me in this very beautiful session. And really a pleasure for me to share our best practices in optimizing endometrial receptivity, particularly the role of progesterone in priming of endometrium. So, if you look, of course, what is actually the receptive endometrium? The endometrium, we said, was receptive if the embryo, the embryo is receptive to embryo during the window of implantations in the luteal phase of the cycles. And I think we know a long time ago when Noyes criteria, and also in 1974, I think there are 3 distinct states following exposure to progesterones: endometrial receptivity, pre-receptive stage, if progesterones lasting from day 1 to day 4, receptive during day 5, or post-receptive period from day 6 onward. So that's why right now, currently at the moment, we always exposure endometrium with the progesterones within 5 days after estrogen priming of endometriums. And currently, endometrial preparation protocol is very important before we do frozen embryo transfer, because nowadays maybe in our country almost 90% the cycles we do the frozen freezing the embryo. So that's why we are very important for us to preparing endometrium for frozen embryo transfer. During endometrial preparation before frozen embryo transfers is essential synchronization between the embryonic and endometrial window of receptivity to attain normal implantations. And then ways to prepare the endometrium for frozen embryo transfer. The most used currently is SRT cycle. Even we know there is also natural cycle, true or modified natural cycle, but currently in our center, particularly in Indonesia, we prefer to do SRT cycles. Estrogens may be administered orally, vaginally, or transdermal. And then many natural estrogen are also synthetic sometimes. No type estrogen supplementation or route was found to be superior. Most likely, estrogen were administered approximately 10 days until 14 days, mimicking the natural cycles. And then we monitored endometrial thickness and patterns by transvaginal ultrasound. Then progesterone administration usually started from endometrial thickness of approximately between 7 to 8 millimeters. If you look this figure, of course, most of us are very familiar. If we prepare the endometrium with the modified natural cycle, or this one is with the artificial cycle or natural cycle, or of course with SRT cycle, we do the estrogen supplementation, and then after we decided that estrogen, that endometrial thickness is adequate enough, then we start to exposure progesterone P plus 5 is when we transfer the blastocyst, or P plus 4 when we transfer the cleavage stage of embryo. And others with modified natural cycle or natural cycle, I think is different with in the modified, we used to trigger with ECG. And as a cycle, we only monitor the spontaneous LH surge. Well, previously we used a stepping up dose of estrogen, but currently we use a fixed dose 3 times daily, estradiol followed by transdermal, and then we expose both vaginal progesterone combined with the dolutestrons 3 times daily and vaginal progesterone twice daily, 90 milligrams. We use the progesterone gel. And then after P+5, we replace the embryos, blastocyst, single embryo transfer. And then after that, we did monitoring HCG level after 2 weeks of the embryo transfer. And then how long the duration of estrogen administration is very important to improving the success rate. If you look this study, they are trying to comparing the live birth with no live birth in the frozen embryo transfer. There is no difference the day of embryo development at transfer, and also there is no difference of embryo quality in terms of ICM and then also trifactorium. Then also there is no different progesterone route, vaginal, progesterone, or intramuscular or combinations. And we can see here the duration, the live birth and the non-live birth were determined significantly because of morphological score of the blastocyst. Of course, the blastocyst stage is more than 4 BC, the favoring live birth and also progesterone route, both is dominant, more favorable compared to the single vaginal, single progesterone supplementation. And then day of embryo transfer, I think this is the favorably loss if the blastocyst day 6 we replace. And then endometriosis and then length of estradiol supplement, there is no significantly difference to induce to pregnancy loss in frozen embryo transfer. And we know that Lotus study, Lotus 1, Lotus 2, and Lotus 3, I think, firstly introduced by George Lisinger. He firstly initiated the non-inferiority clinical trial compared to the micronized vaginal progesterone in Lotus 1 study. He used the oral dedogestrone 3 times daily compared to MVP 600 milligrams. I think this is the weeks of the treatment. We know this is the study, is the protocol is the same. And then we use this is for the fresh transfer. And then we can see here there is no difference in terms of pregnancy rate. This is oral dedogestrone, the 330 milligram compared with micronized vaginal progesterone 600 milligrams, 4 weeks, 8 weeks, and 12 weeks gestation, and also live birth rate. Even the forest plot is a little bit favoring the oral dedogestrone, but there is no difference. That was demonstrating non-inferiority to micronized vaginal progesterone. And also in terms of the perinatal, the pregnancy loss, yes, there is no difference. We can see here, this is number, the day of the embryo transfer. Day 5, then also the number of embryo transfer, there is no difference. And then we can see this is the similar infant safety data. I think the gender, male and female, and I think abnormal finding on physical examination, Apgar score, height, and body weight. Also, there is no difference. And then in the Lotus 2, they're comparing oral dedogestrone with the gel vaginal progesterone, I think 90 milligrams instead of micronized vaginal progesterones. This is the same. This is the embryo transfer. This is after as for the luteal phase support. I think there is no difference. The success rate, the pregnancy rate, ongoing pregnancy rate, and live birth rate between the group with the vaginal gel progesterone with oral dedogestrones. And also this one, there is the character, no difference in terms of the day of embryo transfer, number of embryo transfer, and then also the total, the newborn, There is no difference for both of group. And also infant status at the end of the pregnancy, no different of abnormal finding, physical examinations, Apgar score, first minute and 5 minutes. I think this is just to convince the tolerability and safety use of the dydrogesterons in IVF. And if you look, this is also the other study trying to see how the compliance of the patients receiving vaginal gel progesterone compared with the progesterone group. You can see here the vaginal discharge, vaginal bleeding, interference with coitus, perineal irritations. Yeah, it's significantly higher in the vaginal gel group compared to the progesterone group. And also the satisfactions, most likely the patient receiving the progesterone, they show the higher satisfaction, absolutely, compared to the vaginal gel progesterones. So the Lotus trial indicate higher rate ongoing pregnancy and live birth rate receiving the progesterone. This is in the fresh IVF cycles. This is the as a luteal phase support. Then within the Lotus 3, this will increase odds with the oral progesterone if we use all the aggregate data. We combine Lotus 1 and Lotus 2 trial. And this is actually our study in our center. We did the study on the 104 patients underwent frozen embryo transfer. This is all the inclusion criteria. All the frozen embryo transfer preparation, we use SRT using oral estradiol or transdermal estradiol or combination of both. And then also we use the progesterone combination, vaginal progesterone with the dydrogesterones, 30 milligrams daily, vaginal progesterone twice daily, 90 milligrams. This is exclusion criteria. And then this is 80 patient we can follow. This is we divided into 3 groups. 28 patient HRT using transdermal estradiol valerate, 32 patient using oral estradiol valerate, then 20 patient using combinations oral and transdermal estradiol valerate. If you look, this is our study. This is the group 1, group 2, and then group 3. No difference in terms of the age of the patients, duration of infertility, and also etiology of infertility. There is no difference between these 3 groups. And then totally estradiol administration, more likely is almost the same, between 11 to 15 days. Even some patients, they need to extend the length of estradiol supplementation up to 3 weeks. But there is no difference, I think, in terms of the pattern and also the endometrial subendometrial blood flow. And then this is the transdermal estradiol dose. This is between 36 to 157 milligram. So daily is they receiving most likely 600 milligrams daily. Sometimes we increasing the doses up to 8 milligrams or up to 10 milligrams daily. In some patient who need adding or increasing the doses because of the endometrial thickness is not achieve the standard yet. This is the total dose of estradiols, the transdermal, transdermal, and then oral estradiol. The number of embryo transfer, this one between 1 until 3, so most likely 1 or 2 blastocyst transfer we do. And then in some patients we adding some PRP, but only around 10%, because of if we found the endometrial thickness is not adequate enough, we give the PRP once at least, but it's only around 10 to 20%. But in a combination, sometimes we need to combine oral and then transdermal because of the endometrial still thin, and then in some patients they need supplement. PRP. Yeah, so in the group 3 is higher than the PRP because the endometrium was thinner. You can see here the endometrial is thinner in the group 3. This endometrial thickness during frozen embryo transfer. And then progesterone administration, yeah, we administered the progesterone when at least this one the metal be around 9.5, 8.7 until 9.5 millimeters, and then we supplement the dydrogesterone 3 times a day with the combination with vaginal progesterone twice daily, 90 milligrams. Then this is the pregnancy rate. I think no difference, yeah, in terms of the pregnancy rates. Yeah, this one we can see between these two groups. Yeah, the pregnancy rate is still good. And then if we look the total price also, I think the transdermal, yeah, only of course this is the cheaper one compared to the combination. Combination is much expensive. This is the cost in Indonesian rupiah. So I think this is the our experience in preparing endometrial in the frozen embryo transfer combination by transdermal or estradiol valerate, and then combine with the oral estradiol, or only oral estradiol valerate with combined with the progesterone plus vaginal gel progesterone twice daily. And we have also the data to see how the serum placental growth factors after 4 weeks treatment of the progesterone. This is with the placebo is folic acid only, and then this is the progesterone plus folic acid. This is pre and post after 4 weeks treatment. This is in the first trimester of pregnancy, and we can see how the placental growth factor was increased, was higher significantly in the group of patient pregnant women who received the progesterone 20 milligrams in the luteal phase support in the first trimester. So that's why we believe that the progesterone, instead of its capability for transforming endometrium, also they have immunomodulator effect through placental through progesterone-induced blocking factors, and also through favoring increasing TH2 with the ratio TH2 to TH1. So that's why favoring the pregnancy. And this is also the data, all the data, the pregnancy and the non-pregnant. This is the endometrial thickness, as I mentioned to you before. I think this is all the data after frozen embryo transfer that we use combinations, yeah, the progesterone with vaginal progesterone in all artificial cycles. I think the progesterone is non-inferior, similar endometrial thickness in the both of groups, and then also synchronization is very important. And we believe in the first trimester it's very important the invasiveness of trophoblasts. So that's why to convincing the good invasiveness of trophoblasts, we should convince the luteal phase support, the endometrial transformation by combination vaginal progesterone plus the progesterones. And even in the systematic review, they mention natural cycle or modified natural cycle. It's much better compared to artificial cycle. But if you look this one, the latest data, I think no significant difference here between artificial cycle with NC or modified NC. So that's why the role of progesterone is very important in convincing the success rate of artificial cycles compared to the NC or modified NC. Even they talk that in NC or modified NC there is a corpus luteum. However, I think the artificial cycles is they have a lot of advantages, such as the no burdening patients, and then cheaper, And then it's much flexible for all the patient, including anovulatory women that in the NC or modified NC, the anovulation woman, they cannot do NC or modified NC for the embryo transfer. And this is the again, this is the morbidity, gestational diabetes, NC versus AC modified, NC versus AC. I think no difference. Maternal outcome, preterm delivery, gestational diabetes, hypertensive disorder are relatively similar across NC, modified NC, and artificial cycle. So might show slightly lower risk for hypertensive disorder, but the difference are not statistically significant. So I think this is the newest data that we have in the during endometrial preparation. So I come to my last slide that currently frozen embryo transfer is increasingly used for multiple indications. So that's why optimal preparation protocol is very, very important. Even we have a NC, modified NC, and artificial cycle for the our center. Artificial cycle is the first choice. Is I think almost 100% in our center. We use artificial cycle for preparing endometrium for endometrial transfer, for frozen embryo transfer. And then the crucial step is achieving synchrony between endometrium and embryo development stage. Future research, I think, again, so we should comparing once again at NC, modified NC with artificial cycle to convince that this is the safe method. And then the first trimester is the very crucial period that we should convince the invasive nerve of trophoblast is much, much better to avoiding the morbidity in the second trimester, like uterine artery notching as a least sign of preeclampsia. And then propose to start progesterone intake on the theoretical day of oocyte retrieval in HRT cycles. And then this is a plus P plus 5, or P plus 4 for the cleavage state. And then this is a LH plus 6 or HCG plus 7 in modified or in NC. And then the progesterone look promising in preparation and method transfer with non-inferior result compared to the natural progesterones in the fresh transfer and also in the frozen embryo transfer in our center. The progesterone looks very promising with the good outcome of maternal and also a good outcome of neonatal, and then also with the good compliance of our patient compared to other progesterone preparations such as micronized progesterone or vaginal progesterone only. Okay, I think this is my presentation. Thank you so much for your kind attention. Thank you.
Thank you very much, Dr. Budi Viveko, sir, for a wonderful, brief, precise, and concise, hard-hitting presentation. I'm very pleased to announce that we have a live audience of nearly 1,750 who are viewing this program live, though it's on a Sunday evening. There are a few questions from the audience, sir. If you permit, we will take them right away. The first question comes from Dr. Sarita, and she is asking, which patient profiles benefit the most from dydrogesterone when endometrial receptivity is suboptimal? Is it something which you reserve for a particular patient population, or you can use it for everybody?
In our center, we use a combination of the progesterones, 30 milligrams daily, with vaginal progesterone 180 milligrams for all patients. Endometriosis, PCOS, tubal factor, male factor, and also unexplained infertility. I think with the same good result for all the group of patients.
Very good. The next question comes from Dr. Nilima, and she is asking, could you elaborate on how dydrogesterone avoids the androgenic, glucocorticoid, and mineralocorticoid side effects seen with some other progestogens?
Yes, if you look the properties of the progesterone, we call it in the chemical structure is retroprogesterones. It's really similar actually with natural progesterone, only some carbon part of the carbon atomic they reverse. So that's why I think the properties of dydrogesterone in terms of glucocorticoid and mineralocorticoid is, and also androgenic properties, no androgenic properties, they really similar to natural progesterones. So I think there is no worry, we don't have any worry with the effect of mineralocorticoid, glucocorticoid, or androgenic effect of the dydrogesterone.
Thank you, sir. Another question regarding dydrogesterone and compliance issues. Do you find that the vaginal progesterones are limited by compliance issues, whereas dydrogesterone is more favorable and accepted by our patients?
Yes, as I presented in the data, that most likely the patients prefer to take the tablet actually, progesterone. That the progesterone is preferable actually if for our patient because they are suffering from the very few the vaginal. There no vaginal discharge, no interfere with sexual intercourse, and I think also this is the many. Absolute satisfaction of our patient who receiving that progesterone. However, for the endometrial preparation, we still need combination vaginal properties combined with the oral the progesterones. So both is very important with the effect directly to the endometrium and also the effect through the serum the progesterone, which is they have immunomodulatory effect including progesterone-induced blocking factors, and also in our data, the progesterone increasing also the serum placental growth factors after 4 weeks treatment.
Thank you, sir. Thank you. There's a question from Dr. Navnita from Andhra Pradesh, and she's asking, do you find that dydrogesterone better synchronizes the endometrium with the embryo compared to other progesterones?
Yeah, it's depend on the dosage. Actually, every progesterone properties they have their own dosage, their transformation dose. The dydrogesterones they have the transformation dose. I think around daily is 20 to 30 milligrams, but right now it's 30 milligrams times by 5. I think 150 milligrams is enough for the progesterone to transform endometrial from after priming with estrogens. And the others, the like such as the micronized progesterone, they need up to 200, 600 milligrams if we use oral, or 200 milligram if we use transvaginally, and then it is daily transformation dose. So that's why it's depend on its properties, and then for the progesterone, 30 milligrams daily, it's enough.
Thank you, sir. Thank you. And one final comment from Dr. Praveena Gandhi from Mumbai. She's saying, based on the emerging data, could dydrogesterone become the new standard of care for luteal support in ART worldwide?
I think so. It looks promising, but it is very interesting if you look the data from the Elena Labarta and then the others who trying to measure the serum progesterone before proton embryo transfer, a day before. The data stated that at least 9.2 nanogram per milliliter is needed in the serum progesterone before we decided to perform proton embryo transfer. But it is still should be elaborated. What is how the relationship between serum progesterone concentration with the progesterone, with the endometrial transformation, or with also the dosage, the progesterone concentration in the endometrium. I think this is still a big question. And then the second one, which properties of the progesterone we use? Intramuscular injection or micronized progesterone vaginal or tablet or the dydrogesterones. So I think this is still black box is still a mystery that we should doing the comprehensive study. But we believe right now the combinations, both we need oral the progesterone, which is the best, with the vaginal progesterone. or some or intramuscular, or now we have aqueous water injection progesterone as well.
Thank you, sir. Thank you. There is a compliment for you from Dr. Prashant Mangeshikar. He said he's joined late, but you were just too good. Thanks to Dr. Nandita and Alembic for providing such wonderful and experienced speakers. And he further goes on to say that he hasn't heard something like this for some time now. So congratulations to you, Dr. Budi. And I'm
Thank
sure the
you.
audience has really appreciated your wonderful elaboration on optimizing endometrial receptivity. Thank you, sir.
Thank you so much.
I think we'll move to the next speaker since Professor MosheHod has been waiting for quite some time. Sir is going to speak to us on Femtech in healthcare, and I would like to go ahead and formally introduce Sir. He's well known to us in India, of course, because he's visited India several times. Most recently, I think just last month, and we had the good fortune to listen to him in person. Sir is the professor of OBGYN at the Faculty of Medicine, Tel Aviv University, Israel. He's also visiting professor at the University of Florence in Italy. He's chair for the PIGO Femtech New Technologies and Women's Health Committee. He, in the past, has held several positions, including director of Maternal Fetal Medicine Division at Israel Rabin Medical Center. He is director of the More Comprehensive Women's Health Center in Tel Aviv, president of the European Association of Perinatal Medicine, chair of the Pregnancy and Non-Communicable Disease Committee of PIGO. He is also on the executive board of directors of PIGO as well as the IADPSG, and he is also chair for the board of study for diabetes in pregnancy. He has several advisory and medical biotech startup roles. He's also published more than 300 scientific publications, and he has an RG score of 44.56. He's editor of several textbooks. And today, sir, I think is uniquely placed to give us an overview on the utility of Femtech in healthcare. Over to you, sir. So you'll need to unmute, please.
Sir, unmute, please.
Parna, since you're the host, you can go ahead and send a request. Yeah, I think it's sorted.
Do you see my screen?
Yes, sir. If you could go into slideshow.
I can see it here. Okay, now I see it. All right. I apologize. I had a closed microphone, so now you can hear me, right?
Yes, sir. We can see and
Can
hear
you
you.
hear me?
Perfect.
Okay. All right. Thank you very much for the invitation. I'll try to introduce you to you today to the Femtech revolution. This is, I would say, this is the newest thing, the newest kid on the block that we have right now. And I think that you should be aware of what happens about Femtech. Let's first declare what is Femtech, define Femtech. Femtech is short for female technology, and it focuses on the health and well-being of women. So, in short, technology designed for women's health. Femtech is a term that refers to diagnostic tools, products, services, wearables, software. I'll show you in a second. It was kicked off very recently, 9 years ago. It was coined in 2016 by the co-founder of a Clue application, a menstrual healthcare application, Ida Tin. And since then, this concept gained a huge, huge recognition all over the world. Why Femtech is so important? Why it became so important? Because we have to close a gap. Have a look at the history. In 1977, the USA FDA excluded women of childbearing age for taking part in drug trials. Why? Because of different beliefs that it can harm pregnancy and blah, 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 blah. And So women were underrepresented in drug trials. Those were the beliefs that you see in red, but women were really needed to be focused in the field of technology. Life science research was overwhelmingly tailored for the male body. As a result, yes, we can declare women do lag behind men. It's a fact. 1989 to 1984, 1993, NIH changed the policy, and it was it was a very important move. They called it the NIH Inclusion Outreach Checklist, how to engage, recruit, and replace research with women. So NIH ensures that women and minorities are included in all clinical research. In trials including women and minorities, the trial should be designed and carried out, and so on and so on. So NIH came out with very clear instructions how studies supported by NIH should be designed and how women should be included in them. In 1993, even the Congress, the USA Congress, came by inclusion criteria that they became a law. So now it's a policy that became a federal law. So from March 1994, NIH would not fund any grant, cooperative agreement, on contract or support any intramural project unless it complied with this policy. It's a fact. So the gap is being closed right now, and we are facing the change. So we are actually now facing the femtech revolution. Have a look what femtech is doing to our profession. It's in reproductive health, it's in pregnancy, it's in pelvic health, it's in general health and wellness, and actually in every aspect of our profession as obstetricians and gynecology. Have a look at the product types. We have diagnostics, we have applications and software, devices, whether wearables or hardware. We have consumer products, we have drugs, vitamins and supplements, we have services, we have telehealth, and we have digital platforms. We need more and more digital platforms, and I know that you in India are very productive. I already had a contact with few Indian companies that are progressing very nicely with digital platforms, as well with all the other devices that you see here on this slide. I later come to the platform that deals with pregnancy, because today we'll deal mainly with pregnancy. But let's continue now. So we are closing the gap right now. And have a look what happens to the market, the femtech market, how importantly it grows. In 2025, 21, the market was worth about $25 billion. The prospection that in 2030, it will be about $100 billion. And have a look now on the left here on what's happening now all over the world in sense of femtech production. Over 1,800 companies, over 2,000 investors, and they are looking for more and more investments in startups, in new ideas, in innovations, in femtechs. 30 hubs and communities, 30 R&D centers. The market size, as I already said, 10 subsectors in every aspect of our profession. 55% covered by top 3 subsectors. And we have already 8 product types. So the gap is being closed very efficiently and quickly. This is a November 13, 2023 announcement by the White House. I'm not sure what is it worth now, because the announcement was made by the previous president, Joe Biden, when he appointed his wife to lead this White House initiative on women's health research, actually closing the femtech gap. So they came up with the initiative to boost federal government research into women's health. And I am not sure what's happening to it right now. But even the White House, exactly two years ago, and plus 3 days, came out with this announcement. I'm quite sure that Mr. Trump will do something about it as well. So yes, we are moving forward. Let me bring you with another exciting, I called it exciting quotation for a very, very known person, Sir Winston Churchill, during World War II. He said that never let a good crisis go to waste, meaning that pandemics, economic crisis, and wars. At that time, he was actually leading World War II, the war. And he said that never let a good crisis go to waste. Dramatic change inevitably uncovers fresh insight and point of opportunities for growth. And I marked it in larger, in bold letters here, pandemic. That's actually what we are facing right now. Global health. We have two pandemics that are reshaping global health and especially pregnancy management. One is the COVID-19 pandemic, kicked off in 2020. So we are 5 years behind. And we learned a lot from the pandemic. We were strict. We had to stay at home. We couldn't visit our clinics. We had a lot of educational stuff to do in order to overcome this pandemic. But the most important pandemic, actually for me, kicked off in 2011, and that was the NCD pandemic. NCD, non-communicable disease pandemic, and I'll show you in a second, because the NCD pandemic for me is a big change, and here I actually was chained to my Indian collaborator, Dr. Hema Divakar, and we kicked it off together. And I'll show you in a second how we managed during these 14 years to push forward the NCD pandemic to the advantage of women in pregnancy management. Now, let me use this slide here that was actually developed by Renita Das, and she is a senior partner in a company, in a business consulting company called Frost & Sullivan. This part here belongs to Renita, the impact on the cost of care, and she identified mainly 3 subtopics that she wants to deal with them. And they are menopause, menstrual care in pregnancy in low and middle income countries, fertility solution, and early diagnosis and monitoring of autoimmune and NCD disorders. I asked Renita to push it forward, and I actually added here my connection to Femtech, because right now it's much more than just menopause and fertility, because Femtech and women's health, NCD and cannabinoids are getting more and more attention in sense of the market opportunities or business opportunities for 2030. So NCD, pregnancy as prediction and prevention of non-communicable disease, new technologies, of course, then digital pregnancy management, and mainly one-stop virtual medical care centers for women, what I call point of care management. We want to push more and more towards the point of care management. And then lastly here, cannabinoids. We leave it for another lecture, but cannabinoids are again a very, very promising challenge for the future, mainly for a disease called endometriosis. We came out in my committee that I'm actually leading in FIGO with this special article. Exactly 2 years ago, we saw what's coming out, and we came out with this article, as you see, myself, Hema Divakar, Ann Kihara, who was until last month the president of FIGO, She's from Kenya, Africa, and Michael Geary, the editor of IJGO, the International Journal of Obstetrics and Gynecology. We called it the Femtech Revolution, a new approach to pregnancy management, digital transformation of maternity care, the hybrid e-health perinatal clinic addressing the unmet needs of low and middle income countries. And believe me, that we see here India as well. India can take huge advantage of the program that we are designing here, and I'll show you the case in a second. We pushed forward this idea further, so I called it New Technologies and Women's Health, and today we'll mainly speak about pregnancy. I'm not going to enter to all the other sub-professions that we have, but we'll speak on new technologies in pregnancy. Now, but first, let's define the inequity. We see a huge inequity in management on the perinatal scenario. I call it the perinatal scenario or the perinatal market. We have about, now it's even more, we have almost 140 million live births per year. So let's divide it to high and middle income countries and to low and middle income countries here on the right. Have a look what happens. Have a look on the numbers. In Europe, we have about 4 to 5 million deliveries. In the US, we have 4 to 5 million deliveries. So together, let's make it a median of about 10 million deliveries per year. Have a look what happens on the right side. India in the lead with about 30 million deliveries. And I suspect, and I'll be very glad to hear your comments from the audience that you probably have more. But if you add to India, Pakistan, Afghanistan, Indonesia, Bangladesh, Nepal, Sri Lanka, and Malaysia, the Eastern countries, the Asian Eastern countries will have 55 million deliveries. In Africa, 30 million deliveries, China, 18 million deliveries, and Brazil, about 15. So on one side, we have 10 million deliveries. On the other side, we have almost 130 million deliveries. But have a look what happens in sense of guidelines. All the guidelines are being produced here. European Society of Perinatal Medicine, EBCOG, ACOG, SMFM. So everything is being produced on the left side. But all the deliveries and all the complications are actually here on the right side. So the only organization that can take guidelines and adapt them, correct the inequity, is FIGO. And that's actually what we are doing. We are taking account, we are evaluating the guidelines that we ourselves produce. I, as president of EAPM, produce guidelines for Europe, but we have to adapt them to make them feasible, workable in low and middle income countries. And that's exactly what FIGO is doing. FIGO is correcting the inequity because FIGO is the international professional organization that combines all the society around the world. Over 130 countries are under FIGO, and FIGO's vision is for women of the world to achieve the highest possible standard of physical, mental, reproductive, sexual health, and well-being throughout their life. So that's what we do. That's exactly what we want to do in FIGO. I kicked off in FIGO in 2011. Here you see with my best friend, Dr. Hema Divakar, and with Margaret Cho, at that time, the General Director of WHO. Hema and myself, we were invited to the United Nations in New York to present our case, the FIGO case of non-communicable disease. And Margaret Chan, after our meeting, after our talks, after our collaboration with her, she came up with an editorial at the New England Journal of Medicine that she called Slowing a Slow Motion Disaster. NCDs, we are facing a slow motion disaster. And she actually declared here that there is an increasing global crisis in NCD. NCDs are associated with mortality, morbidity, and long-term disability, and 2 out of 3 deaths globally are attributable to NCDs. But the main take-home message, the one that we are processing right now, that are NCDs, they are being programmed and imprinted during pregnancy. Thus, diagnosis and management during pregnancy may help turn down the NCD pandemic. And thus, pregnancy is the window of opportunity to prevent NCD. So that's why Emma and myself, for the last 14 years, are pushing forward this agenda. Yes, pregnancy is a window of opportunity, and we must do whatever we can to prevent any complication during pregnancy, and thus to prevent future non-communicable disease. I'll skip through it again. That's the long-term fight against NCD. It was clearly stated. I came out with a special editorial in IJGO connecting maternal fetal medicine to non-communicable disease prevention. And that's actually our target that we are pushing forward. Pregnancy is the window of opportunity to prevent future NCD. And that's how we continued. Emma and myself, me as the chairman of this pregnancy and NCD committee, starting here, and then the committee is here, that's the committee. We came out with all the guidelines and best practice advice between 2015 and 2023 in 8 years, guidelines on every pregnancy complication, gestational diabetes, preeclampsia, post-term, fetal growth retardation, preterm labor, whatever you want, you have them here. 7 guidelines that we produced, 7 guidelines and best practice advice, and actually they are based on what we produced in high-income countries, but actually can be used exactly the same adapted way in low-income countries. For gestational diabetes, for example, we followed the Indian example and collaborating with Dr. Sheshaya from Chennai and adapted the guidelines that should be used in India. Because in India, you can't use the guidelines that are being used in the US or Europe, how to diagnose GDM. So we adapted the Indian guidelines and it works perfectly. Now have a look what happened later. In 2024, Emma Divakar was appointed to be the division director of Division of Well-Being Healthcare of FIGO. And under this division, Emma has 5 committees. The Committee on Adolescent and Youth Care, Committee on Breast Health, Committee on Women at Reproductive Age, and Committee on Women and Menopausal Age. The 5th committee is mine, Committee on Women's Health and New Technologies, that we call it also the Femtech Committee. And here I am very proud to have with me the leading expert on perinatal medicine, AI, and whatever you want. Aris Papagiorgio from UK, Vincenzo Berghella from the US, Moses Ombimbo from Kenya, Hassan Shehata from the UK, and Mahesh Chulani from Singapore. Then other representatives like Nandita. Nandita is here with us from India. Eline van der Beek, she is the R&D chief of Nestlé, Switzerland. Bhaskar Bhatt from India, that you probably know him very well, a brilliant guy. Vita Senikas from Canada, Justin Conji. And as ex-office trustee, we have Ann Kihara, FIGO immediate past president, as our co-member with us in the committee. And we have a very, very ambitious plan how to push this agenda forward, the agenda that I already showed you about the digital revolution and the digital transformation of maternity care. Our article received a huge, huge applause, and we were considered the top viewed article in 2024. Let's have a look for a second on traditional pregnancy management. 14 visits advised by ACOG based on tradition. No more than tradition. The FIGO solution, that's what we are pushing together to do more and more point of care and home testing. And we propose that we can do it in 8 meetings and maybe even less. We can do even less. But we need to collaborate with you, my Indian colleagues. Your input will be extremely important. And I know that there are many, many startups, many very interesting Indian companies that are willing to push this agenda forward. And yes, we have to push it forward. Then ACO tried to come up with a solution for them, but they didn't make it. ACO provides general ideas and is heavily focused on the EDI aspects of care. We, ACOG, the document, our vision, and the committee's activities, recommendations, especially are trying to implement in the US. We want to have it in LMIC. So we base our intervention on 3 interventions. First, the pre-pregnancy cares. We want to involve family plannings and assignment for prior risk of NCD, and then to prepare them for pregnancy. The second intervention is the first trimester and early second trimester, and I'll show you in a second. And the third intervention, what I call now the 4th trimester, that's the post-delivery, post-pregnancy follow-up. That's a new invention, a new name. It doesn't exist yet in the literature, but I call it the 4th trimester. It's extremely important. So how do we create this hybrid perinatal clinic? And those are the visits. Pre-pregnancy and first trimester, where we want to do prediction and prevention of pregnancy complications, preconception counseling. So everything is here. That's the first meeting. Then the second meeting will be here, early first trimester, 6 to 8 weeks, confirmation and risk assessment. First meeting will be first trimester, 11 to 13 weeks, pregnancy complication assessment, again, prediction and prevention. Then moving forward, here are the other 4, early second trimester, 18 to 22 weeks, 28 to 30 weeks. Delivery is already 7th meeting, and the 8th meeting is postpartum, what I call the 4th trimester. And then we go separately. We go for the offspring, neonatologist, pediatrician, and the mother, OB-GYN, as well as all the other specialists, whether it's a diabetologist, cardiologist, or whoever she needs. More and more obesity care now. So in pregnancy, actually, we have only 6 meetings, whereas delivery is already the 7th, and the 8th is the postpartum. And here are all the devices that we can use during this ordeal. And again, I'm repeating, there are many devices that are being developed in India. I won't mention them, but many of them are here. You can identify them probably here. We can use each one of them, and the main just come with an idea and bring it to us. We want to use any device that can be used at the point of care of home setting. Every device. Just to mention sonography, home sonography, the device, it's an Israeli company, the device, had received an FDA approval about 4 days ago. So home sonography is already recognized. And here is the life cycle. I call it the life cycle. We already mentioned it. Preconception management, first trimester, then second and third trimester already diagnosis management, the just follow up, delivery, and then it comes to the 4th trimester with postpartum management. Offspring health in the hands of the neonatologists and pediatricians, and maternal health, of course, goes all the way through here, because any complication during pregnancy will result in an NCD. If it's GDM, there is a 60 to 80% chance of having a type 2 diabetes, obesity, hypertension, cardiovascular disease, mental. And here we see all the committees that are under HEMA's division. There are menopause, breast health, reproductive health, adolescent and youth health, and new technologies. Those are the initiatives that we are doing. We are leading in my under division, and especially in my Femtech committee, managing maternity using AI, Internet of Things, IoT, and point-of-care testing devices. The future of Femtech, moving care, not people, already submitted for publication, will be very soon published. Getting it right, the use of tech-enabled nutrition. Eline van der Beek, It's being prepared right now. Personalized multiple micronutrient supplement in pregnancy, femtech and AI tools by timing and adherence already submitted, will be published very, very soon. Modern management of pregnancy in preparation right now, and we'll deal with it very, very quickly. So those are already all the subjects that were interviewed, approved, and we are moving forward. Those were the two sessions that we actually produced right now in Cape Town 2 months ago, and those were fully attended sessions where we presented our Femtech revolution and AI new technologies for better management of pregnancy. The last that I would like to mention is very, very interesting for you as well. A group of endocrinologists, actually the Endocrine Society, came out with, again, what I call the inequity. They came out with a consortium publication, a guideline, pre-existing diabetes and pregnancy, and Endocrine Society and European Society joint clinical practice guidelines. Excellent guidelines. But what do they lack? No word about low and middle income countries. Again, 10 million deliveries. So they're talking for 10 million deliveries here. Nothing about LMIC. So we immediately came out with a response, and we came out with an editorial that you see here, diabetes technologies for pregnant women with hyperglycemia in pregnancy, an opportunity to address global inequity. And it was by Aris Papageorgiou, Hema Divakar, Fionnuala McAuliffe, and myself. It's already submitted, accepted, will be published very soon. And will come out with a publication very similar to this one. Devices, technologies, where whatever you want, new technologies and pregnancy management, but mainly adapted for use in the real world for low and middle income countries, which means for 130 million deliveries that are all over the world in low and middle income countries. Thank you very much for your attention. And I do hope to have more and more input from India, because India is crucial for our development. You have over 30 million deliveries per year. It's unbelievable. Nobody can cope with it. But we need to find the right way how to lead India towards more and more success in pregnancy management. Thank you very much.
Thank you, Professor MosheHod. A wonderful presentation on Femtech and how India has one of the largest number of deliveries and is beautifully poised to take advantage of the Femtech revolution once it finally does take off. We have a few questions from the audience, sir, and with your permission, we'll go ahead and take them. The first question is regarding gestational diabetes mellitus. And the question is, how can Femtech play a role in this, and specifically in LMICs like India? What should be the correct approach to tackle the metabolic disorder which manifests during pregnancy?
Excellent question. And it's a huge burden for you in India. And actually, you have excellent experts in India who deal with it and come up with solutions. The Chennai group is excellent. And Hema and myself, we are pushing forward these ideas. And the question is great. We have to try first and predict GDM in the first trimester. There are new tools now for prediction. We are working now, we are looking now for more studies and more funding, but a wearable device, you see my watch. We have a watch now that can measure non-invasively from this side of the wrist continuously glucose values. It's already now under FDA approval. As soon as we get it, again, we are looking now for Indian investors, for Indian market, but as soon as it will be feasible, imagine you can put this watch early in pregnancy, wear it until 24 to 28 weeks of pregnancy, when you do the diagnosis of GDM, then collect all the data that you had from early weeks of pregnancy up to 24, 28, and come up with an algorithm that will predict you what GDM. So we won't have to do a GDM diagnosis. We'll have a prediction. If we'll have a prediction of GDM, we can try and prevent it. So that's a very, very long run. But we are looking still for other tools, how to diagnose GDM at point of care. There is another solution. There is a British company that has a home OGTT. You can get in an envelope to your home the home OGTT kit. You just perform it there, send it back. You don't have to come to the clinic, and you'll have the result at whenever it's decided in your community. India has very, very specific, and we allowed it in FIGO recommendations how to diagnose GDM. So
Awesome.
it will be easy, and we are going to use these two tools, home OGTT, prediction of GDM using various continuous monitoring techniques, and come up with a solution for low and middle income countries as India.
A smartwatch sensor that 24/7 monitors your blood glucose sounds amazing, and that will truly revolutionize the pace of diabetes care, especially in pregnancy in our country. The next question comes from Dr. Yogesh Gadekar, and his question is regarding semaglutide, which has been introduced in a big way in India. What are your thoughts? Do you think India is going to witness a lot of momentum on these weight loss drugs?
On what's, excuse me, which device?
Semaglutide, Ozempic, Wegovy, and Mounjaro.
I'm not sure I'm familiar. What is it? What is it?
They are weight loss drugs, sir. GLP-1 agonists and GLP plus GIP agonists.
Okay, all right, okay, I got you. Yes. I don't think we can use them in pregnancy. Not yet.
No, they're obviously
not yet. No, not yet. I am a very big fan from the early 2000s of oral management with oral hypoglycemic agents of GDM. And the first study came out by Oded Langer in 2000 in the New England Journal of Medicine when he was still in San Antonio, Texas, allowing Gluben and other metformin or other oral hypoglycemic agents to be used. I am not sure that there is any study yet that will allow you to use this new pharma in pregnancy. So not yet.
The next question comes from Dr. Radhika Rani from Guntur, and she says, with mobile health platforms increasingly being used to track early pregnancy symptoms, do you observe any associations between specific hormonal support patterns and more stable digital physiological markers?
Please, what is the precise question? Because it's a bit vague here. So what is the...
It's very general, and she's asking whether specific hormone patterns are established and can these be relied on with digital monitoring, or would you require peripheral blood testing, which is traditional way?
So you mean it's glucose or other hormones?
I think she's referring to glucose as well as other hormones, especially the hormones which are used to do first trimester screening.
I am not familiar with other. What do you use for glucose screening, for GDM screening as hormones?
No, we use the single value. We use the WHO test. We use the WHO test, single step, single value.
Blood sugar is excellent. We use it everywhere. We can use it as with glucometers, with Libre, with continuous glucose sensors, but it's still not very, very accurate for diagnosis. But still, in areas that you can't use a laboratory, very accessible laboratory device, then you can use whatever you have. So if you have a glucometer, or you have a Libre that you have from time to time, use it. It's reliable. It's much better than not doing anything.
Thank you, sir. Thank you. There are two questions from an international perspective. First is Dr. Abdul Rahman Al-Jabi from Sharjah. I hope I've got the pronunciation right. Apologies if I haven't. And his question is, can integrated digital platforms detect hormonal patterns and use those to predict high-risk pregnancies?
No, unfortunately, we don't have them right now. And you don't have any platform that will actually diagnose all of the complications. It has to be specific complications. I am very, very familiar with prediction, especially using genetic markers. A very new genetic markers is small RNAs, microRNAs. We already published few papers using microRNAs and prediction of GDM and prediction of preeclampsia. But there is no one complete digital marker that can actually diagnose a high-risk pregnancy. You have to do it step by step. You have to go by pregnancy complication. And I'm seeing more and more applications from startups that are using various biomarkers, many other biomarkers, not only genetic biomarkers, for preterm labor, for GDM, for preeclampsia, for FGR. But there isn't one combined biomarker to identify them all.
Not yet. We haven't found the magic solution as yet. Human intervention and clinical expertise will always take priority. One final question from Dr. Mohammed from Philippines, and he says that I think India has created a lot of guidelines, but customizing them on a country-to-country basis is important. Would you agree, Professor Paul?
Absolutely. And thank you very much for this question. Absolutely. That's exactly what we are doing in FIGO, because we know that there is no general rule that can be applied everywhere. That's why we allowed India in the FIGO guideline to use their methodology. And India is doing this perfectly. What you do in India is plausible. It's great. There is one in China that we allow to do it differently, using only fasting glucose. So yes, we will be willing to work with any other association that will come up with a solution for their own specific population. We'll be very glad to give a hand and come up with something together. Bravo, it's an excellent question.
Thank you, sir. Thank you. There's a question from Dr. Ronak Hamdani, and he's from Dubai. And he says India has excellent doctors, but he wants to know the technology part for pre-pregnancy weight loss and use of weight loss drugs. Do we have any kind of integrated solution or system where this can be accomplished?
Again, thank you very much. That's a great question. As you probably noticed in one of my slides, the pre-pregnancy visit, one of the main targets is obesity. Obesity is the biggest killer now in our world. And the same goes for pregnancy. Yes, we would like these women with obesity to come for a pre-pregnancy evaluation and to prepare them for pregnancy. I'm working now in my committee for guidelines to push forward more and more obesity clinics in pregnancy, which means you have to start before pregnancy. Then you can use still the new obesity drugs, anti-obesity drugs. I don't want to go into them, but you probably know what I mean. There are many new anti-obesity drugs now that can be used. You can't use them in pregnancy, but yes, you can use them in preparation of pregnancy. But these guidelines are still have to be produced and worked out. Yes, the solution is there. We have to come up with ideas how to bring these women before pregnancy to prepare them to reduce gain, and then how to follow them up during pregnancy.
Thank you very much, Professor Moshe, for a wonderful talk and drawing our attention to all the different ways in which technology can optimize pregnancy, childbirth, and women's healthcare throughout the world, not only in India, but throughout the entire world. Thank you very much for taking the questions, and thank you for your precious time on this Sunday evening. We'll proceed to the final talk of the day, which is going to be delivered by none other than Dr. Nandita Palshetkar. The talk is on this important subject of boosting fertility naturally the emerging role of coenzyme Q10 in male and female reproductive health. Madam has already been introduced earlier at the beginning of the program, and unfortunately, she is traveling, so she will not be able to deliver this talk live, but she has recorded her talk. And I would request the backend team at Science Integra to please go ahead and play the recorded video, please. So while they're getting set up, I'm very pleased to announce that we have a live audience of over 2,000 viewers on this Sunday evening. Thank you, everybody who has logged in and who's taken the trouble to actually ask us questions. Very interesting, thoughtful insights revealed through those questions as well.
Good afternoon, everybody. It's really a pleasure to be here at this international CME organized by Alembic and Science Integra. Infertility today is influenced not just by age and lifestyle, but also by the invisible burden of oxidative stress. We see more couples struggling with poor gamete quality, mitochondrial dysfunction, and unexplained infertility. Adjunctive strategies really become essential. Today, I want to share the evidence behind one such molecule, the coenzyme Q10, and how enhancing mitochondrial health can translate into better biological function, better gametes, and better ART outcomes. This is what my talk is going to cover, and let's get on with it. Uh, Globally, infertility affects nearly 1 in 6 couples. This burden is increasing due to what? Delayed childbirth, lifestyle factors, environmental toxins, and oxidative stress. This makes it very essential for us to explore adjunctive therapies that support reproductive physiology. In India, this prevalence actually ranges from 10 to 15%, and in some urban pockets, even higher. The psychosocial burden is immense, creating a growing demand for evidence based supportive therapies, and these include antioxidants such as coenzyme Q10. Both male and female factors contribute almost equally today. And what is concerning is the rising proportion of male factor infertility, which is largely driven by declining semen quantity, obesity, pollution, and chronic oxidative stress. There are multiple factors affecting fertility: age, lifestyle, environment, exposures, endocrine disruptors, and oxidative stress. Actually, these are the key contributors. Today, I will focus on oxidative stress, its impact, and the emerging role of coenzyme Q10 in restoring reproductive function. Now, let's look at the impact of aging. Aging affects both the gametes, the sperms, and the eggs. Advanced paternal age increases DNA fragmentation, declines the sperm function, and elevates the risk of adverse reproductive outcomes. For women, oocyte competence drops rapidly after 35. One central mechanism behind this decline is actually oxidative stress. So let's look at the pathophysiology. Oxidative stress sits at the core of infertility pathophysiology. It's essentially the balance between the reactive oxygen species and the body's antioxidant defenses. So, ROS is required in small amounts for normal reproductive physiology, such as follicular development, corpus luteum function, and capacitation. But when ROS rises excessively, what it does is it damages lipids, DNA, proteins, and membranes. This balance is what we call oxidative stress when the balance really tilts. So if you look at it, ROS is generated continuously, and this system is very dynamic. In excess, what does it cause? Lipid peroxidation, DNA fragmentation, apoptosis, and mitochondrial dysfunction. So lipids are the ones which are present in the membranes of the cells. And obviously, the cell membrane gets affected. So all these factors directly impact the sperm and the oocyte quality. Let's look at the male reproduction. Around 30 to 80% of the infertile males actually show elevated oxidative stress markers. ROS impairs sperm membranes, reduces motility, impairs capacitation, and increases the DNA fragmentation. Protecting the sperm mitochondria is therefore very, very essential. If we look at the female reproduction, ROS regulates folliculogenesis, steroidogenesis, ovulation, implantation, and luteolysis. But excess ROS actually disrupts follicular growth, depletes the ovarian reserve, and impairs oocyte competence. It contributes also to other diseases like endometriosis, PCOS, poor ovarian reserve, and age-related decline. Oocyte aging is strongly linked to mitochondrial dysfunction. Excess ROS accelerates meiotic errors, zona pellucida hardening, spindle abnormalities, and embryo development failure. During ART, oocytes and sperms are often exposed to oxidative stress at multiple steps. From follicular environment to lab handling, ROS can influence fertilization, embryo grading, and implantation. And this is where antioxidants really become very clinically relevant. So, what is the impact on reproductive system? Overall, oxidative stress disrupts the entire reproductive system, the endocrine function, the gametogenesis, the embryo development, the implantation, and the pregnancy maintenance. In fact, I want to mention a little bit about the endocrine disrupting chemicals. These these environmental toxins like phthalates, bisphenol A, pesticides, they directly increase the oxidative stress. They reduce the AMH, impair spermatogenesis, and disrupt the hormonal signaling, worsening the infertility outcomes. What is the role of coenzyme Q10? It acts, we know, on the mitochondrial level. It's a key electron transporter and the only lipid-soluble antioxidant synthesized in the body. It's declined with age, and it directly actually impacts the gamete quality. Let us classify the different types of antioxidants. They include enzymatic ones like the SOD, catalase, and non-enzymatic ones like vitamin C, E, and Q10. Among these, coenzyme Q10 is unique because it supports dual function, energy production and oxidative protection. So if you look at the basics, it's abundant in tissues with high metabolic rates like ovaries, testes, endometrium. In fact, in the oocyte, it is one of the highest, having 2 to 3 lakh copies. Decline in mitochondrial coenzyme Q10 leads to reduced ATP, impaired meiosis, and defective sperm motility. You can see all this. So let's go to the clinical evidence. So coenzyme Q10 boosts ATP production, as I mentioned before. It stabilizes the mitochondrial membranes and neutralizes lipid peroxidases. Essentially, coenzyme Q10 improves cellular respiration and protects reproductive cells from oxidative injury. What about the male infertility? Multiple trials actually show that coenzyme Q10 improves sperm concentration, motility, and antioxidant capacity. In fact, dose-dependent improvements have been observed with 400 milligrams a day showing greater benefits than 200 milligrams. After 3 months of supplementation, the seminal TAC, SOD, and the CAT levels improve significantly. Motility and concentration rise due to better mitochondrial efficiency and reduced DNA fragmentation. Coenzyme Q10 reduces DNA fragmentation, improves endocrine levels, and increases spontaneous conception rate. Even 200 milligrams per day actually shows meaningful improvement. So the clinical meaning is really very clear. Coenzyme Q10 is an effective first-line supplement in idiopathic male infertility and improves partners' pregnancy rates. Let's look at the woman. A meta-analysis in the Journal of Assisted Reproduction and Genetics shows that coenzyme Q10 supplementation actually doubles the clinical pregnancy rate from 28% versus 14.1% in women undergoing ART. If you further analyze this meta-analysis and go into subgroups, the effect remains significant in poor ovarian reserve and PCOS subgroups, both conditions linked to mitochondrial dysfunction and oxidative stress. Coenzyme Q10 in the follicular fluid is also very important and has been studied extensively. Higher coenzyme Q10 levels in follicular fluid correlate with better oocytes morphology, higher grade embryos. This was the first study demonstrating its presence and role in human follicular fluid as far back as 2012. Taken together, coenzyme Q10 definitely improves oocyte quality, fertilization rates, embryo grades, and ART outcomes, particularly in older women and those with POR. So let me, summarize the evidence for you. Multiple meta-analyses and RCTs on coenzyme Q10 demonstrate improvement in semen parameters for the male, improved ovarian reserve in the woman, higher fertilization rates, and greater likelihood of clinical pregnancy. The key takeaways from this talk are, if you look at the biological takeaways, reproductive health depends on a delicate redox balance. Both oogenesis as well as spermatogenesis require controlled ROS. When oxidative stress overwhelms the system, the gamete quality declines sharply, and this in turn affects the infertility. And the clinical takeaways. Coenzyme Q10 is the only endogenous lipid-soluble antioxidant. Evidence supports its role in improving both sperm and oocyte quality, enhancing IVF ICSI outcomes, especially in POR and PCOS. It's simple, effective, and has the excellent safety profile. To conclude, reproductive physiology relies on finely controlled redox balance. When oxidative stress disrupts this balance, both sperm and oocytes are compromised, and so are our ART outcomes. Coenzyme Q10, with its unique mitochondrial role, offers a simple, scientific, effective way to support fertility naturally. It's not a magic pill, but it is meaningful, evidence-based tool in our armamentarium. Thank you very much.
So thank you, Dr. Nandita Avshekar, ma'am, for a wonderful talk on boosting fertility naturally, emerging role of coenzyme Q10 in male as well as female reproductive health. And we present apologies on behalf of madam because she's traveling. She's on a plane. She had to pre-record this talk a little while earlier. I believe there are one or two questions from the audience for ma'am, so we'll take them. I am not sure whether she'll be able to join us live, so I think I'll have to answer the questions on her behalf. The first question is from Dr. Sheetal. Do you believe that coenzyme Q10's extensive safety data justifies broader use in preconception metabolic optimization, particularly in women with PCOS or advanced maternal age? So that's a difficult question to answer because as yet we don't have the evidence to my knowledge. But yes, many of us who practice fertility exclusively have been using this molecule in other classes of infertility as well, including PCOS and advanced maternal age, as you point out. But we still await a large meta-analysis with multicentric data, which will be able to cast light and give us the appropriate conclusions regarding its use in optimization of the metabolic profile in women preconceptionally. The second question is from Dr. Alida Clerk from Philippines. I hope I've got the pronunciation right again. Apologies if I haven't. Considering the age and cost effectiveness, does coenzyme Q10 have a role in improving equity of care, especially in resource limited fertility settings? I think what she's trying to say is if we can prescribe this for women who are awaiting maybe ART, does it increase the chance of natural fertility, etc.? Again, this is something which is not extensively studied. We don't as yet have data regarding this particular issue. So again, this is a space which is very much open to discussion. We'll still need to await more studies regarding these wonderful new molecules which are available to us. Having said that, more and more of us in clinical practice are using coenzyme Q10, and we are seeing improvement in both the oocyte quality as well as the sperm quality. Whether that translates into better clinical pregnancy rates, better live birth rates, optimization of the metabolic profile of the woman prior to undergoing ART, all of these is something which remains to be seen. I am pleased to announce that we have 2010 live audience for today's program. Can I request the Alembic team to present the final vote of thanks?
Hi, sir. This is Trupti from Alembic Pharmaceuticals. I would like to extend my sincere gratitude and lot of appreciation to both our international speakers, Dr. Moshe as well as Dr. Budi, for their wonderful lecture. It was very insightful, and I'm sure that the count of the audience also speaks loud about how interesting these sessions are today. But sincere thanks from the entire team Alembic to Dr. Moshe, Dr. Budi, Dr. Nandita, and yes, nonetheless, yes, sir, to you, to Dr. Pratik for moderating this session and being such a wonderful host. Thank you so much, sir.
So thank you very much, Science Integra and Alembic for this amazing new initiative, Knowledge Beyond Boundaries. And we look forward to the next episode. Thank you very much, audience, for tuning in. And yes, Science Integra will be preserving the recording and we'll be sharing it with you shortly. Thank you again. Goodbye. God bless. And we'll see you in the next one.